there's been a dramatic change in the way we take care of patients with valvular heart disease due to more information on the natural history and some of these really, really great interventions that we currently have. And overall, what we'd like to do is to be able to intervene on these patients before the onset of deterioration of left ventricular function or further valve problems. So we'll be presenting an overview on the different valvular disorders and how we currently manage them here at Mayo Clinic. I'm Rick Deshimura. I'm a consultant in the Department of Cardiovascular Disease at Mayo Clinic, Rochester, Minnesota. And we will be discussing a manuscript called Valvular Heart Disease, a New Paradigm, that will be appearing in the February issue of the Mayo Clinic Proceedings. In the past, what we've always done in patients with valvular heart disease was to operate open heart surgery, replacement with either a tissue prosthesis or a mechanical prosthesis. Now, in the past, there was a very high operative risk to this type of intervention, and the valves themselves would end up deteriorating at 8 to 10 years for tissue valves or require very, very high dose anticoagulation for mechanical valves, resulting in complications of bleeding, infection, so on and so forth. But what we've been finding is that the natural history of patients with valvular heart disease is much different than we initially thought. We initially thought that patients could go on for years and years and years, and it was only with the onset of symptoms would we feel that they would deteriorate and in that time perform the valve intervention. But what we're finding now is that if we have these patients with valvular heart disease go for a period of time, even if asymptomatic, we know it's going to be affecting the left ventricle, and with left ventricular dysfunction, the prognosis overall would be much poorer than if we could intervene earlier and earlier. In addition to knowing the natural history, we now have great interventions that can be done with a much lower risk and a much greater outcome. For instance, with open heart surgery, the risk of an aortic valve replacement, which used to be 8 to 10%, now is down to less than 1%. And the valves, both tissue valves and mechanical valves, last a much longer period of time. And if we use a mechanical valve, the bleeding risk is substantially lower because we do not have to have them on the higher doses of anticoagulation. Finally, what we're seeing is the introduction of catheter-based therapies so that by inserting a valve on a catheter, let's say through a femoral artery, while the patient is still awake, we can implant the valves in the different positions without the need for open heart surgery. So overall, there's been a paradigm shift in valvular heart disease in which we are going to be intervening earlier and earlier before the onset of left ventricular dysfunction and overall provide patients with a much better quality of life and a much longer lifespan. So for patients, this means that number one, they need to be identified earlier and earlier. So anybody who is found to have a heart murmur, for instance, on routine physical examination, should undergo a further evaluation with two-dimensional and Doppler echocardiography. And if they are found to have significant stenosis or regurgitation on one of the valves, even if they feel well, even if they're able to do whatever activity they want, they should be evaluated to be considered for early intervention. For clinicians, this means that one really needs to evaluate each patient very, very closely who is found to have any type of valve disease. The physical examination is essential because this will lead one to pre-test probability of whether or not the valve disease is significant or only mild to moderate and can be followed. Following your physical examination, an extensive two-dimensional and Doppler echocardiogram should be performed. And one should be able to find concordance between the physical examination and the echocardiogram to determine if the valve is mild to moderate or moderately severe, and whether now it's at the point that it could be impairing left ventricular function. So that's that concordance and the clinical assessment that's very, very necessary. But if in fact the valve is found to be significant, the patient should be referred to a valve team, now consisting of a cardiologist, an interventionalist, surgeon, anesthesiologist, to determine the best approach for the patient. In the past, we used to have master clinicians who would use their stethoscope, who would use look at an electrocardiogram, look at a chest X-ray, and be able to make a diagnosis. Now, our training has evolved so that many physicians are not able to do this, but the information that our master clinicians had was all digital. Heart sounds can now be recorded with an electronic stethoscope. The electrocardiogram is a lot of digital information. There's a lot of digital pixels on a chest X-ray. And what is being done now is the use of artificial intelligence to be able to analyze these digital signals so that, yes, indeed, we can make an early diagnosis of valvular heart disease at any place in primary care settings in third world countries, so on and so forth. And then once that diagnosis is made, then further evaluation is warranted. So a big approach is early diagnosis, as we know now that about 50% of patients who have significant valve disease are not necessarily being referred when they should be. The manuscript that we're publishing will go over a general concept on how to look at valve disease and the changes in the natural history and the changes in interventions. But then we'll be going into each specific valve problem: aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, and tricuspid regurgitation, and outline in detail what one needs to look for in these patients and when we should be considering intervention. In addition, we'll also talk about the newer interventions. For instance, in surgery, not only can we do valve replacement, but we can do valve repair with a much better outcome. And as I stated before, catheter-based therapy is rapidly advancing now, allowing us to treat these patients, what we call non-invasively, with valves placed through catheters so that a patient can have a procedure done while fully awake and actually be dismissed the next day, back to work within a week.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.